Anticoagulant management for inpatient acute care nurses. Competency. Objectives. Once this learning module is completed, the nurse will be able to verbalize the concepts of anticoagulant management, differentiate between low molecular weight unfractionated heparin and warfarin indications and complications, identify common indications for the use of anticoagulants, verbalize potential drug interactions and monitoring needs for anticoagulants, discuss patient and family education needs related to anticoagulants. Indications for use of anticoagulants. Prevention and treatment of atrial fibrillation, atrial flutter, deep vein thrombosis, pulmonary embolism, stroke, aortic or mitral valve mechanical valve replacement, hypercoagulable disorders. Coagulation cascade. Understanding the basics of blood clotting is essential in understanding anticoagulation options. Clotting factors are circulating in the bloodstream in an inactive form. Clotting factors are proteins that must undergo a change in structure to be activated. Clotting factors are initiated by an initial vascular injury. Pathways of the coagulation cascade. Intrinsic, extrinsic, common. All function collaboratively to stop bleeding. Clotting cascade. Please take a moment to review the clotting cascade.
At the site of vessel injury, the first platelets arrive to start sealing the wound. Simultaneously, the coagulation cascade with its various coagulation factors is activated. This involves two pathways, the extrinsic and the intrinsic pathway. Extrinsic activation begins with now exposed molecules of the vessel wall, such as tissue factor, which forms a complex with factor 7. Finally leading to the activation of factor 10. This factor 10A is the point at which the extrinsic and the intrinsic pathways of the coagulation cascades meet. The intrinsic pathway consists of various coagulation factors activating each other in a chain reaction. At its end, a complex with an additional cofactor is formed. This complex now activates factor 10. Since the two pathways merge at the level of factor 10A, this factor has a pivotal role in the coagulation cascade. Further down the cascade, factor 10A in combination with 5A activates thrombin and induces the so-called thrombin burst. One molecule of factor 10A can catalyze the formation of 1,000 molecules of thrombin. These large amounts of thrombin cause the further activation of platelets and the enhanced formation of fibrin. Fibrin then forms strands, making up the mesh that stabilizes the platelet plug in an arterial clot and holds together the red blood cells in a venous clot. It can be concluded that the central role of factor 10A in the coagulation cascade makes it a viable target for therapeutic intervention in pathologically altered blood coagulation.
Cascade. It's a life-saving part of normal human physiology. The process can be altered by cancer, prolonged immobility, or genetic disorders, resulting in life-threatening complications. Anticoagulation agents act at different points of the cascade to treat or prevent clot formation. Unfractionated heparin works by inactivating thrombin, factor 2A, and factor 10A, primarily used in prevention and treatment of deep vein thrombosis and pulmonary embolism. Can be used in the management of unstable angina, acute myocardial infarction, angioplasty or stent placement, and is the anticoagulant of choice in pregnancy or breastfeeding women. Dosing is based on the patient's weight, whether used for prophylaxis or the treatment of thrombotic conditions. It requires close monitoring and has a narrow therapeutic range with an increased potential for bleeding and a potential for heparin-induced thrombocytopenia, HIT. The most common side effects are nosebleeds, gum bleeding, coughing up blood, blood in the urine, dark tarry stools, and hemorrhage. These incidents increase with the elderly and renal failure. Reminder, Alaris guardrails. Any IV-infused heparin must be on an Alaris pump, and the guardrails program must be turned on when the heparin is infusing to prevent infusion-related medication errors. Heparin-induced thrombocytopenia, HIT. It is an antibody-mediated reaction. It is a profound decrease in platelets, 50% reduction in baseline, and it can happen within 5 to 10 days of exposure to heparin. This is potentially life-threatening. Discontinue all heparin and other anticoagulants. Patient education includes an increased risk of bleeding, monitoring for bleeding, managing bleeding if it occurs, and drug-specific information. Low molecular weight heparin drugs, enoxaparin, diltiazem, tenzaparin. All are preferred agents in the acute treatment of pulmonary embolism, used in deep vein thrombosis prophylaxis, post-knee and hip replacement surgery. Used for treatment and prevention of venous thromboembolism and acute coronary syndrome. Has a predictable dose range, dose-independent clearance, long half-life, lower risk of HIT, reduced need for laboratory monitoring. Safety implications. Anti-10A, low molecular weight heparin, monitoring may be warranted for specific conditions. Obesity, small stature, impaired renal function, and pregnancy. Bleeding risk is less, but protamine phate intravenously may be used to reverse major bleeding events. Due to cross-sensitivity, do not use in patients with history of HIT. Patient education. Increased risk of bleeding, monitoring for bleeding, managing bleeding if it occurs, drug-specific information, and instructions on subcutaneous administration techniques. Direct thrombin inhibitors. Used if HIT occurs as an alternative to anticoagulation options. It interacts directly with the thrombin in the common pathway to inhibit clotting. Requires PTT monitoring. Activated clotting time if using bivalirudin. No antidote to reverse these agents. Must monitor closely for bleeding. Side effects are bleeding, fever, nausea, and vomiting. Fondaparodox, Arixtra. Used in pulmonary embolism, deep vein thrombosis, treatment and prevention. Hip fractures, knee and hip replacements, abdominal surgeries. Not to be used in patients with severe renal impairment or if less than 50 kilograms in weight. Side effects: bleeding, weight-related as to severity, spinal or epidural hematoma, current alternative for HIT patients requiring anticoagulation. There is no antidote. You must monitor for bleeding. Warfarin, Coumadin, oral anticoagulant. It is preferred to heparin and low-weight molecular weight heparin for long-term anticoagulation. It focuses on the clotting factors and protein D and S in the coagulation cascade. It is approved for prevention and treatment of DVT, atrial fib, heart valve replacement, and myocardial infarction. It is preferred for long-term treatment of pulmonary embolism. Monitoring and safety. It is widely used and has a narrow therapeutic index. It requires lab monitoring for dose titration, INR. 2 to 3 times normal for thromboembolism, treatment or prevention. 2.5 to 3.5 times normal for high-risk patients. It takes 2 to 3 days for the INR to reflect dosage changes, so no daily increase in dose. If on heparin and transitioning to warfarin, must continue heparin for at least 24 hours after warfarin INR levels are met. Usually 5 days of overlap is needed. Stable patients are monitored every 4 to 12 weeks, depending on the physician. Side effects: bleeding, frequently in the GI tract, skin necrosis, cholesterol embolus syndrome. It's contraindicated in pregnancy. Old age, active hepatic disease, and certain drugs are likely to enhance the response to warfarin. No routine use of vitamin K. For rapid reversal of effects, prothrombin complex concentration, or PCC. In serious circumstances for bleeding, you can give IV vitamin K in addition to PCC. Direct drug interactions. The table below shows medications that affect a patient's INR. Increases in INR, decreases in INR, increases bleeding risk. Patients do not have to avoid foods rich in vitamin K, but must be consistent in their consumption in order to regulate the anticoagulation therapy. For example, if a patient eats a lot of leafy green vegetables, they must do it on a consistent basis. Patient education. Medication compliance. Take the medication the same time every day. No missed doses. Avoid interacting drugs, including OTCs and herbals. Seek medical help with bleeding. Hold during menstruation. Use a soft bristled toothbrush. Use electric razor. Avoid cutting self. And carry a medical alert card or wear a bracelet. Pill colors. Regardless of manufacturer, each tablet strength has a corresponding color. 1 milligram is pink, 2 milligrams lavender or light purple, 2.5 green, 3 milligrams tan, 4 milligrams blue, 5 milligrams peach or light orange, 6 milligrams teal or blue-green, 7.5 milligrams yellow, 10 milligrams white. Dabigatran, Pradoxin. Prevention of thromboembolism, stroke, in non-valvular atrial fibrillation patients. A direct thrombin inhibitor. Has a fixed dose of 150 milligrams daily by mouth. Off-label, it's used for post-op hip and knee replacement surgery prevention of DVT. There's no monitoring requirement. Decreased drug-drug and drug-food interactions. Side effects and cautions. Major bleeding events. It must be adjusted in patients with kidney impairment. There's risk increases with age 75 or older. Risk of bleeding increases with history of recurrent stomach or intestinal bleeding or stomach ulcers. Severe dyspepsia, second most likely side effect. No reliable reversal method. Patient education. Even minor injuries can cause bleeding. It must be stopped for a short period with dental work or surgery. No spinal injections or epidurals. You must seek medical attention for incidents of unexpected or severe bleeding, unusual or unexpected bleeding, pink or brown urine, red or black stools, any unexpected pain, swelling, or joint pain, headaches, and feeling dizzy or weak. Do not stop the medication unless told to do so by the doctor. Risks of bleeding increases with aspirin, NSAIDs, and blood thinners. Verapamil and quinidine demonstrate decreased absorption with Paradox. Apixaban, Eliquis. It is a direct thrombin inhibitor. DVT prevention in post-hip and knee replacement. Prevention of stroke in non-valvular atrial fibrillation patients. Treatment of DVT or pulmonary embolism and to lower risks of repeat episodes. Medication is 5 milligrams by mouth twice a day is the recommended dose. Side effects and cautions. Major bleeding events. It must be adjusted in patients with kidney impairment, liver disease, older than 80, if they weigh less than 132 pounds. It can cause serious blood clot around spinal cord with spinal tap or epidural. This can result in paralysis. There's no reliable reversal method. No monitoring is required. There's decreased drug-drug and drug-food interactions. Patient education. Even minor injuries can cause bleeding. It must be stopped for a short period with dental work or surgery. Do not stop unless told to do so by a physician. Drug interactions, potent CYP3A4 inhibitors, aspirin or clopidogrel. Rivaroxaban, Xarelto. It's a direct factor 10A inhibitor. It blocks clotting at the convergence of intrinsic and extrinsic pathways. It's dosed at 10, 15, or 20 milligrams once daily. DVT prevention post-op hip or knee replacement. DVT prevention with non-valvular atrial fibrillation. Monitoring and safety implications. No monitoring of coagulation function needed. Renal function monitoring is recommended periodically. Contraindicated for use in patients with active liver disease. Avoid if on antiplatelet agents. Underweight or elderly are shown to be more sensitive, demonstrating increased coagulation response. Potential drug interactions. Azole antifungal medications. Antiviral drug Retnovir. Phenytoin. Carbamazepine. All dosing. Please take a few moments to look it over. You've completed the anticoagulation competency education. Please now take the test.